I have no relevant financial disclosures. First, we'll begin talking about otitis media. Of course, we have to begin with acute otitis media. This is a classic image that no one could miss. We see the bulging tympanic membrane with inflammation going along the malleus and coming across the surface of the tympanic membrane. And clearly there's white pus behind the tympanic membrane, and this is the sort of situation that has kept many parents and children up at night. So the management of acute otitis media has been analyzed quite a bit over the years, and in a review paper in Pediatrics in 2004, recommendations for the management of uncomplicated acute otitis media were summarized. So the definition of acute otitis media involves three factors. First, the rapid onset of signs and symptoms of middle ear effusion and inflammation. Second, the presence of a middle ear effusion on examination, which could include a bulging tympanic membrane, decreased mobility of the tympanic membrane, an air fluid level behind the tympanic membrane, or otorrhea in the setting of perforated acute otitis media. And finally, there should be the presence of middle ear inflammation. So in addition to fluid behind the eardrum, you would expect inflamed vessels on the surface of the tympanic membrane and inflammation of the long process of the malleus and the tympanic annulus. To make this diagnosis, we look at the clinical signs and symptoms of our patients, and often these can be nonspecific. We also do examination of the ear using pneumatic otoscopy and tympanometry. It's important to discuss the anatomy of the normal tympanic membrane so that we can determine when it is abnormal. And this image shows a normal tympanic membrane. And here we can see the long process of the malleus. Now it's important to note that there are often bright red blood vessels on the surface of the tympanic membrane over the long process of the malleus, and these are normal. You can also see blood vessels in the skin of the ear canal, and again, these are normal. But what you don't see are blood vessels along the surface of the tympanic membrane. The tympanic membrane is translucent. You can see areas of brightness. For example, this is the cochlear promontory seen through the tympanic membrane, and that looks bright. This is the shadow of the round window niche, which looks dark. This is the bright spot of the incus and the capitulum of the stapes and the stapedius tendon. All these structures can be seen through a healthy tympanic membrane, and it's not necessarily important to know exactly what the structures are, except to say that they do look different. There are light areas and dark areas, and that we can recognize that there is not a complete effusion behind this eardrum. Pneumatic otoscopy is also critical in determining whether the middle ear is normal. In this video, we see pneumatic otoscopy being performed in a healthy tympanic membrane. You can see the tympanic membrane is moving easily. There's no color change, suggesting that there's no inflammation of blood vessels on the surface of the tympanic membrane, and the degree of movement suggests that there's no fluid behind the tympanic membrane. In this video, we have an ear with acute otitis media. Note now, with positive pressure, there is still movement of the tympanic membrane. It's not completely immobile. However, you can see with application of pressure, there's blanching of the tympanic membrane, and you can actually see a fluid level moving up against the middle surface of the tympanic membrane as the pressure is being applied. And again, here in a different area of the tympanic membrane, you can see clearly there is movement of the tympanic membrane. However, you can also clearly see the inflammation on the surface of the eardrum, and that lets us know that indeed this middle ear does have effusion and inflammation. So now that we've made our diagnosis using pneumatic otoscopy and assessing the symptoms of the patient, we have to make a decision of how to treat. First of all, the 2004 paper from Pediatrics allows for diagnostic uncertainty. It's acknowledged that it's hard to diagnose ear infections in kids. Not every child sits perfectly still. These patients are often in pain and uncomfortable and won't let you get a good look. And the eardrum can become red with crying, which can make it more difficult to make our assessments. So it's okay to be uncertain about who has acute otitis media and who does not. The recommendations for who should get an antibiotic are divided into certain diagnosis and uncertain diagnosis, and categorized by age. For children under 6 months, where it is suspected that there is otitis media, whether or not the diagnosis is certain, these patients should be treated with antibiotics. For children who are greater than 2 years of age, it is acceptable to observe acute otitis media and to offer antibiotic treatment if the illness is severe and the diagnosis is certain, or observation if the illness is not severe. In the age group between 6 months and 2 years of age, antibiotic treatment should be offered for all patients where the diagnosis is certain, But when the diagnosis is uncertain, it's acceptable to observe and to follow up closely. New guidelines were released in 2014, which assessed new data since the 2004 paper. And the key difference here is that the idea of diagnostic uncertainty remains, however, the laterality of the infection becomes more important. So again, in all children with severe acute otitis media, greater than 6 months of age, antibiotics are offered. But for children who do not have severe acute otitis media, when it is bilateral, it's recommended that antibiotic treatment be utilized. If the infection is unilateral and non-severe, then the option of observation versus antibiotic treatment may be given to the patient. If antibiotics are chosen, amoxicillin is the best choice for first-line treatment. The amoxicillin should be given at the high-dose formulation with 80 to 90 milligrams per kilogram per day, divided BID, and this is appropriate for most cases. This high dose will cover susceptible and intermediate pneumococcus. For unsusceptible cases or resistant cases, amoxicillin with clavulanic acid, again at 90 milligrams per kilogram per day of the amoxicillin component, should be given. And this is appropriate for severe illnesses, for children who have concurrent purulent conjunctivitis or a history of amoxicillin failure. And this will also cover beta-lactamase producing H. flu and Mucociliary catarrhalis. When augmentin or amoxicillin with clavulanic acid fails, there are additional antibiotic choices, including oral agents such as ceftonir, azithromycin, clarithromycin, erythromycin, and sulfasoxazole, or sulfamethoxazole and trimethoprim. And if oral options are not successful, intramuscular ceftriaxone may be given. Generally, it's recommended that at least 2 to 3 doses of intramuscular ceftriaxone be given for refractory acute otitis media. The typical bacterial pathogens in acute otitis media include strep pneumo, non-typable H. flu, and Mucociliary catarrhalis. It's important to note that viruses are present in 40 to 75% of isolates, and often viruses do play the key role in acute otitis media. Of note, an increase in H. flu and a decrease in strep pneumo have been seen since the introduction of the PCV13 vaccination. It's important to reassess patients being treated for acute otitis media, and generally a reassessment 48 to 72 hours after initiation of treatment is appropriate. This is to confirm whether the acute otitis media remains present, to rule out other illnesses, and if acute otitis media remains present, to start antibiotics, or if antibiotics have not been initiated, to change antibiotics to a stronger regimen. It is important not to treat persistent effusions, as middle ear effusion will often last for several weeks after acute otitis media. And this is where it's important to be able to differentiate inflammation in the presence of an effusion from a simple effusion without inflammation or signs or symptoms of pain. It's also important to counsel patients regarding the prevention of acute otitis media. Vaccination, especially against influenza, is key to reducing the frequency of acute otitis media. Breastfeeding has shown to reduce the frequency of acute otitis media, and it is recommended that exclusive breastfeeding for the first 6 months of life will reduce the frequency of otitis media in infants. Pacifiers, exposure to tobacco smoke, and daycare have also been associated with increased rates of acute otitis media. In summary, it's important to first make the diagnosis, and that's based on clinical signs and symptoms, the use of pneumatic otoscopy for examination of the ear, and tympanometry to help confirm middle ear effusion. Antibiotics should be used when appropriate, and close follow-up should be maintained to assess for antibiotic response or for the need to initiate antibiotic use if they have not been started at the initial visit. And finally, it's important to counsel patients and their families for prevention of acute otitis media. The next topic is otitis media with effusion. And we can see in this image there is an effusion behind the tympanic membrane with an air fluid level and air bubbles here. But note the absence of inflammation. Again, we see small vessels on the tympanic annulus, but the surface of the tympanic membrane is free of inflammatory change. In a clinical practice guideline released in 2004, the American Academy of Otolaryngology and Head and Neck Surgery made recommendations for the management of otitis media with effusion in children aged 2 months to 12 years. The first guideline is to correctly diagnose otitis media with effusion. This is an effusion without signs or symptoms of inflammation, and pneumatic otoscopy is recommended for examination of the tympanic membrane. It's important to document the laterality, the duration, and any associated symptoms, because the management is dictated by both the duration and the symptoms of otitis media with effusion. This can be based on the current exam, the onset of a previous acute otitis media, if the diagnosis is being made with a recent otitis media on that ear, or by the onset of hearing loss if a family presents for the chief complaint of decreased hearing and effusions are identified at that visit. It's also important to distinguish the child at risk. Children who have a risk of speech delay due to permanent hearing loss, independent of otitis media with effusion, due to a suspected or diagnosed speech and language delay or disorder, children with autistic spectrum disorder or other syndromes such as Down syndrome or craniofacial disorders, children with blindness, children with cleft palate, and children with other developmental delay are at high risk for speech and language delay. And the management of otitis media with effusion in these children tends to be more aggressive than in children without these risk factors. For children who are not at risk, watchful waiting is appropriate. Otitis media with effusion, when bilateral, should be observed for at least 3 months prior to any surgical intervention. 75 to 90% of post-acute otitis media effusions will resolve by 3 months after the initial acute otitis media. This waiting period may include interval visits, and typically at 6-week intervals are considered appropriate. It's also important to note that while we are observing these patients, hearing loss may be present, and it's important to counsel families on how to manage hearing loss during these times. For children who are in school, they should have preferential seating in the classroom, and teachers should be made aware that the hearing loss exists. For families with children at home, they should be made aware that children may not hear quite as well, and eye contact should be made before giving important instructions or trying to get a child's attention. It's important in managing otitis media with effusion with watchful waiting to test the hearing after a 3-month interval. If there is only mild hearing loss, it is considered appropriate to continue with observation in the case that the child has no risk factors and no speech delay. If there is moderate hearing loss, or for an at-risk child, intervention at this point is appropriate. The data for language outcomes following early tube insertion in otitis media with effusion are mixed, and one long-term study showed that speech outcomes do equalize by school age. Other management during this time is somewhat controversial. However, there are good data to show that antihistamines and decongestants do not speed the resolution of otitis media with effusion and can have adverse side effects. Additionally, antibiotics and steroids do not have long-term benefit. There are modest short-term benefits for antibiotics in some trials in otitis media with effusion. However, there are adverse effects associated with antibiotics, including GI side effects and allergic responses. And it has been shown that nasal steroids alone are not effective in speeding the resolution of otitis media with effusion. So in summary, otitis media with effusion should be diagnosed appropriately. It is important to document the time of onset, the laterality, and associated symptoms, and it's acceptable to use the onset of such symptoms as the starting point of the otitis media with effusion. It's critical to distinguish the child at risk, as earlier surgical intervention is appropriate for the at-risk child. Observation should be carried out for 3 months for bilateral otitis media with effusion. Generally, medications are ineffective at speeding the resolution of otitis media with effusion, and surgery should be reserved for symptomatic or at-risk patients. Regarding surgical management of otitis media, a clinical practice guideline released in 2013 discusses recommendations for surgical management of acute otitis media and otitis media with effusion in children. This guideline first defines recurrent acute otitis media as 3 episodes of acute otitis media in a 6-month period, or 4 infections in 1 year, with 1 infection being recent. Another recommendation of this guideline is that an abnormal middle ear exam should be present in at least 1 ear at the time that surgery is being discussed. With regard to otitis media with effusion, surgery is recommended with bilateral myringotomy with tube insertion when bilateral effusions have been present for 3 months with symptoms such as hearing loss or speech delay, or in the at-risk patient, as defined in the previous slide. Myringotomy with tube insertion is also recommended for children with acute otitis media with a poor response to treatment, such as children who have failed to respond to multiple oral and, in some cases, IM antibiotics. Myringotomy with tube insertion is also indicated for children with acute mastoiditis or intracranial complications of otitis media. Also, in children without effusion who do have retraction pockets or dangerous chronic changes to the tympanic membrane, myringotomy with tube insertion is warranted. The risks of myringotomy with tube insertion include general anesthesia, failure for the tube to extrude, which generally occurs at a rate of approximately 2% for grommet tubes, the risk of perforation, which occurs at approximately a rate of 2% for grommet tubes and as high as 17% for T-tubes or longer-lasting tubes, the risk of tube otorrhea or drainage through the tube, and the risk of laryngosclerosis. This image demonstrates laryngosclerosis of the antero-inferior tympanic membrane, which is a white patch in this area. And this is actually quite common in children who have had tube insertion. Generally, laryngosclerosis does not result in hearing loss or other problems. However, in severe cases, conductive hearing loss can be associated with extensive laryngosclerosis. Other surgery for the management of otitis media would include adenoidectomy. This is commonly recommended for children who have had one set of tubes that have subsequently extruded and who have developed recurrent acute otitis media or otitis media with effusion. In these cases, adenoidectomy is recommended in conjunction with a second set of tubes to prevent the need for a third set of tubes when that set extrudes. As the adenoids obstruct the eustachian tube orifice and harbor bacteria which can contribute to acute otitis media, removal of the adenoid tissue often helps to treat this problem. This is especially helpful in children who develop otitis media with effusion over the age of 4, where often the eustachian tube function is normal and it is obstruction from the adenoids that is causing the dysfunction. In general, myringotomy alone has been shown to be ineffective for the treatment of otitis media with effusion or acute otitis media, as spontaneous closure occurs after 2 to 14 days with recurrence of the previous symptoms. And tonsillectomy has not shown to be effective for reducing the rates of either acute otitis media or otitis media with effusion in children. And it's important to note that there are increased risks of tonsillectomy in comparison to adenoidectomy alone, including the increased risk of bleeding and the increased postoperative pain with subsequent increased risk of dehydration. Now I'd like to talk about sinusitis in children. Sinusitis is defined as an inflammatory condition of the paranasal sinuses, and the term sinusitis does not define or imply a particular etiology. It's important to characterize the duration of sinusitis, and it's divided into acute, subacute, and chronic sinusitis. The condition may be infectious or non-infectious, and in children it's often confusing. It's hard to know whether that chronic runny nose for 4 weeks is due to sinusitis, or adenoid hypertrophy, or allergies, or simply nasal obstruction for some other reason. In order to be healthy, sinuses need 3 things. First, the ostia or openings of the sinuses must be open. Second, there must be adequate mucociliary transport within the sinuses. And third, the sinuses must have an appropriate quantity and quality of mucus. The ostiomeatal complex is defined as the region where the sinuses drain into the nasal cavity. In this area, the ostiomeatal complex drains the frontal and anterior ethmoid sinuses and the maxillary sinus in a space between the middle and inferior turbinates into the nasal cavity. This is aided by proper mucociliary transport. The sinus mucosa is lined by respiratory epithelium that contains motile cilia, and these cilia beat uniformly in the direction of the sinus ostium. This is why it's important in sinus surgery to incorporate the natural ostium into any opening made into the sinus, as a secondary ostium will not allow for drainage, as the cilia will simply carry mucus towards the first and natural ostium. Ostiomeatal obstruction can lead to sinusitis, and obstruction of the ostiomeatal unit may be caused by inflammation from a viral upper respiratory infection, anatomic abnormalities within the nasal cavity such as septal deviation or enlargement of the turbinates, swelling due to allergic rhinitis, or due to ciliary problems such as ciliary dyskinesia, which would result in stasis of mucus within the sinuses and subsequent edema. Signs and symptoms of sinusitis in children are different depending on the child's age. In children less than 5, it's common to have respiratory symptoms consistent with a viral upper respiratory infection, malodorous breath, and fever may or may not be present. In children greater than 5, the same symptoms tend to occur. However, children typically also have headache and facial pain. As such, it's important not to rule out sinusitis in a young child due simply to the absence of headache or facial pain. Imaging can be helpful in the diagnosis of sinusitis. Historically, sinus X-rays were used, which can demonstrate an obvious air fluid level in the maxillary or frontal sinus, but generally, sinus X-rays have been shown to be relatively nonspecific. One option for imaging to avoid a full CT scan of the sinus would be a limited CT scan of the sinuses, which includes 5 cuts plus a scout film. The scout film allows for an assessment of the size of the adenoids, which is important for later management. And the 5 cuts show the frontal, anterior ethmoid, maxillary, posterior ethmoid, and sphenoid sinuses. The differential diagnosis of sinusitis in children also includes other entities, such as a nasal foreign body, seen here, hypertrophy of the adenoids, seen here, hypoplastic sinus, mucocele, or inflammatory conditions, such as Wegener's granulomatosis. The differential also includes antrochoanal polyp, which is seen in this video. In this case, a large polyp emanating from the maxillary sinus and obstructing the ostiomeatal unit is being grasped and withdrawn from the nasal cavity. Often children who undergo removal of an antrochoanal polyp do need further management of underlying allergies. The differential also includes neoplasms, such as juvenile nasopharyngeal angiofibroma, rhabdomyosarcoma, and congenital nasal masses, such as a nasal dermoid, glioma, or encephalocele. The microbiology of sinusitis differs between acute and chronic sinusitis. Acute sinusitis reflects the same microbiology as acute otitis media, with strep pneumo, H. flu, and Moraxella catarrhalis being most common, and group A strep also being present. Chronic sinusitis tends more to include alpha strep, Staph aureus, and strep pneumo, as well as Haemophilus influenzae, and in both cases, isolates are often sterile or contain viral mediators. Antimicrobials are commonly used for the treatment of sinusitis, and the choice of antibiotic generally reflects similar choices as in acute otitis media. There is some controversy as to whether antibiotics are necessary or effective in the treatment of acute sinusitis in children, as frequently acute sinusitis will resolve spontaneously with symptomatic treatment alone. And in this randomized controlled trial from Pediatrics in 2001, patient outcomes, in fact, did not differ in any of the groups at any point, with the groups including placebo, amoxicillin, and amoxicillin with clavulanic acid. So in summary, acute sinusitis should initially be treated conservatively. We should try to avoid treating viral upper respiratory infections as sinusitis with antibiotics and simply observe these with supportive and conservative measures. If purulent nasal discharge is persistent for more than 10 days, sinusitis is likely, and antibiotic prescription is reasonable. No drug has been shown to be superior to amoxicillin, and the recommended course is 10 to 14 days, with high-dose formulation of amoxicillin being used. Antihistamines and decongestants may be helpful in sinusitis, and they improve patient discomfort. For clinical failures, amoxicillin with clavulanic acid should be considered, and also clindamycin or high-dose cephalosporins in association with an oral steroid can be helpful. Unfortunately, in the group of children who are most commonly afflicted by recurrent sinusitis, preschoolers, nothing works for long as they get frequent colds, and it's important to counsel families that children in this age group will frequently get 7 to 8 episodes of viral upper respiratory infections each year, and that this is normal. And in acute sinusitis, where the symptoms are confusing or resolution is not occurring, imaging may be appropriate. For chronic sinusitis, treatment with oral antibiotics plus or minus oral steroids should be carried out for a longer period of time. 21 to 28 days is appropriate, and computed tomography at the end of this course of antibiotics will be helpful to determine whether additional treatment, especially surgical treatment, is necessary. For clinical failure or multiple recurrences, first-line surgical treatment includes adenoidectomy alone. Other workup, including an allergy evaluation, immunologic workup, and consideration of a ciliary biopsy to rule out mucociliary dysfunction, is warranted. And finally, failing these interventions, endoscopic sinus surgery is helpful in these cases. The goal of endoscopic sinus surgery is to improve the ventilation of the sinuses. For pediatric sinus surgery, it's important to have specific pediatric instrumentation. The choice of local anesthetic is important, and anesthetic should be weight-based. Often in adults, a large quantity of local anesthetic is used, but we can quickly get to toxic doses in young children if a weight-based measurement is not taken. It's important to note that the dimensions are smaller in children, and it's helpful to have image guidance in sinus surgery for children. With these things taken into consideration, safe sinus surgery can be performed in children. I'd like to review now some special cases in sinusitis. First, orbital complications of sinusitis. Orbital complications of acute sinusitis are classified into 5 stages by the Chandler classification. The first stage is periorbital or preseptal cellulitis. This involves swelling of the eyelids in the absence of orbital symptoms, so there should be no proptosis, no chemosis, and simply we have swelling of the lids, and this is thought to be due to vascular congestion. The next stage of progression is stage 2, orbital cellulitis. In orbital cellulitis, the orbital contents are inflamed without abscess, and this generally results in some proptosis, some chemosis, and possibly limitation of extraocular movements. The next stage in progression is subperiosteal orbital abscess, which is seen in this image. In this axial CT, through the orbits, you can see a normal right globe and orbital contents, and on the left side, we see a subperiosteal orbital abscess with the periorbita being deflected laterally, a fluid collection medial to the periorbita, and the globe being deflected laterally and anteriorly. This is generally something that requires surgical intervention if the collection is large. The fourth stage of the Chandler classification is orbital abscess, where a fluid collection is present within the orbital space. And finally, cavernous sinus thrombosis is when infection extends to the region of the cavernous sinus. This often results in bilateral disease, and these patients are extremely ill and may appear septic. When orbital complications are present, it's important to consult both otorhinolaryngology and ophthalmology for evaluation. Often, surgical intervention is necessary in the case of abscess. IV antibiotics are mandatory, and nasal decongestants and steroids may also be helpful to speed the resolution of treatment. Surgical management may involve endoscopic sinus surgery or external decompression of abscesses. Another special case is the hypoplastic sinus. In this series of CT images, we see in coronal view the normal left maxillary and left anterior sinus, as well as the normal left frontal sinus, with an absent frontal sinus on the right, absent anterior ethmoid, and very small hypoplastic opacified right maxillary sinus seen here and here. On more posterior views, we see that the posterior ethmoids and the sphenoid sinuses are normally developed. It is thought that hypoplastic sinuses form from an early obstruction of the ostiomeatal unit, and in this case, the presence of normal posterior ethmoid and sphenoid sinuses and the hypoplasia of the anterior ethmoid, frontal, and maxillary sinuses suggests complete obstruction of the ostiomeatal unit at an early age with full failure of pneumatization of these sinuses. Hypoplastic sinus can result in what is known as the silent sinus syndrome, where the globe on that side falls inward and down due to the lower orbital floor, and these patients can have chronic headache and facial pain. Another special case is cystic fibrosis. This is an autosomal recessive condition which results from a mutation in the CFTR gene and a subsequent abnormality in chloride transport, which results in thickened secretions, recurrent pneumonia, pancreatitis, and sinonasal polyposis. Management of the sinuses in these patients is very challenging, may require many surgical debridements, and often benefits from frequent antibiotic and sometimes steroid irrigations. Another special case is immunodeficiency. Children with relative immunodeficiencies are at higher risk for infections, especially ear infections, sinus infections, and pneumonia. And in cases where there are refractory ear infections or sinusitis that are not responding to numerous recommended treatments, an immunologic workup may be appropriate, including total IgA, IgG, IgM, and IgE, with IgG subclass measurement and antibody titers for strep pneumo, Haemophilus influenza, and tetanus to correlate with vaccination history and assess the patient's immunologic response to their vaccination. I'd now like to discuss two special cases. This first patient presented with a chief complaint that they were told their child has Wegener's disease. This family came in a complete panic. They had looked up Wegener's on the internet and saw terrifying things and were really afraid that their child was going to die. The chief complaints and symptoms were nosebleeds, headache, and eye pain lasting for approximately 7 years, that is, this child's entire life. They had frequent nasal congestion with mild nasal discharge and frequent upper respiratory infections. There was also a history of cutaneous abscesses, dental abscesses, and infection with molluscum contagiosum with frequent superinfections. This child had mild midface asymmetry, prominent anterior nasal septal vessels, and a nasal exam which was otherwise within normal limits. A CT scan of the head had been obtained and this was reviewed. Again, we see coronal images without contrast through the midface. And we can see on the first image a normal maxillary sinus on the right and a very small maxillary sinus on the left with normal ethmoid and frontal sinuses. And again, as we move posteriorly through the sinuses, we see the normal right maxillary and abnormal left maxillary sinus. And again, here and here. This is a case of a hypoplastic maxillary sinus. First, this patient was reassured that they did not have Wegener's granulomatosis, and blood work was done to confirm this case, and in fact, that blood work was negative. The patient was referred to immunology due to their frequent cutaneous and respiratory infections, and found to have low pneumococcal antibody titers, low complement, and reduced T-cell proliferative responses. They were taken to the operating room for septal cautery for the epistaxis and for left maxillary antrostomy to open the symptomatic left hypoplastic sinus. This resulted in resolution of the epistaxis and resolution of the headaches. The patient continued to have frequent upper respiratory infections and is being actively managed by immunology. The second case is of a 10-year-old presenting with chronic cough and nasal congestion since 6 weeks of age. The patient has a history of recurrent and chronic sinusitis and underwent adenoidectomy at age 5. He subsequently underwent endoscopic sinus surgery at age 7 with transient improvement lasting for several months. He now presents with 3 years of continued sinus symptoms. A workup had been performed, including a sweat test which was negative, a ciliary biopsy which was non-diagnostic due to an inadequate specimen, and an immunologic workup which showed a low tetanus titer, and subsequent revaccination resulted in a good response. The patient also initially had a low IgE and subsequently developed normalized IgA levels. On examination, the patient had mild erythema and white secretions within the nose. Flexible nasopharyngeal endoscopy revealed no masses, no adenoid regrowth, and mild laryngeal edema. The patient was treated with 3 weeks of amoxicillin with clavulanic acid and a topical nasal steroid. At that point, imaging was obtained. The SCOUT film in lateral view shows minimal adenoid tissue present. It shows complete opacification of the maxillary and residual anterior ethmoid sinuses in coronal view. And the posterior ethmoid sinuses do show some mucosal disease as well as the sphenoid sinuses. The patient was brought to the operating room where bronchoscopy and repeat ciliary biopsy were performed. Motile cilia were seen on light microscopy, and normal ciliary architecture was seen on electron microscopy. There was no active pulmonary disease present. The patient subsequently underwent revision endoscopic sinus surgery. It was noted that the previously performed maxillary antrostomies had completely remucosalized, resulting in the observed obstruction of the sinuses. The patient underwent revision maxillary antrostomy and revision anterior and posterior ethmoidectomy, as well as sphenoid sinusotomy, and the patient realized marked symptomatic relief, which continues now 18 months after surgery. Of note, the patient was maintained on topical nasal steroids and saline irrigation. He also underwent CF genetic testing, which was heterozygous for 2 mutations in the CFTR gene, which, when present in trans, may be pathologic. He continues to have multidisciplinary management of this finding. In summary, in children, most sinusitis isn't true acute bacterial sinusitis, but really represents a combination of upper respiratory infections, adenoid hypertrophy, and allergy. It's important to apply diagnostic criteria when possible. We should try to avoid treatment of URIs with antibiotics and consider common causes first. In cases of refractory disease, a thorough investigation is warranted, and complex treatment, including surgical treatment, may be necessary.